For the third time in AIOS. This is Walking Hand in Hand, as we have named it. My co-host is Dr. Shoman Mondol with me in this session. I'm Dr. Sudipta Mitro from Kolkata, a phaco-refractive surgeon. And I would like to play a video at the beginning. This session is about two surgeons supporting each other in the surgeries or showing their skills in management of similar cases. Initially, we came up with a male and a female surgeon walking together. And now, please wait. Yeah. As I say, the video has audio, please. Huh? 1 minute, huh? So it has audio.
With me through all eternity. Have faith, believe in me. Give me your hand. Walk hand in hand with me. Walk hand in hand, walk with me. Be not afraid, for I am with you all the while. So lift your head up high and look up to the sky. Walk hand in hand with me. Walk hand in hand with me through all eternity. Have faith, believe in me. Give me your hand. Walk hand in hand. Be not afraid, for I am with you all the while. So lift your head up high and look up to the sky. Walk hand in hand with me. Walk hand in hand. Be not afraid, for I am with you all the
Yeah, please stop them. So today in Walking Hand in Hand Intraocular Surgeries, we are going to discuss a survival toolkit where a posterior segment surgeon walks with a anterior segment surgeon. We'll be having 6 capsules, and I would request the chairpersons, unfortunately they're yet not present, Dr. Natarajan and co-chairperson Dr. Partho Biswas. I think they'll be joining shortly. I would request the panelists to come and join in stage. Dr. Manisha Agarwal, Dr. Vinit Ratra, Dr. Sheetal Mahuvakar, Dr. Abhinandra Gupta, I think, is he there? Dr. Manisha Nada, Dr. Swaraj Bhattacharya, Dr. Vaishali Lokhande, and Dr. Shugato Paul. Please join us on stage.
The design of each capsule has been set so that there is one particular topic, as you have seen, which will be dealt with from an anterior segment surgeon's point of view, and then from a posterior segment's point of view. Like, for example, if you have glaucoma, we will be discussing about the secondary glaucomas that usually we see following VR surgeries, followed by when a glaucoma surgeon has any complication, maybe para-operative or post-operative complication, where a posterior segment surgeon needs to be dealt with, how it is taken care of. So all the capsules have been dealt with, keeping this in mind. Without further ado, may I request Dr. Sudipta Mitro to present her first capsule, her topic of the first capsule.
Yeah, my topic for the day is victory over vitreous, anterior segment surgeon's view of managing PC rent and a zonular dialysis. There's a bit of audio, sir. Just put a light audio. So this was a case of traumatic cataract with iodialysis and adherence because there was a ceiling fan which had fallen, so there was difficulty. I used the hooks to secure the dialysis portion. The rotation was not good, so I went for a stop chop. Everything was going all right, except when I tried to lift up the one hemisphere which was towards our dialysis, I noted the whole bag and the capsule coming towards me. So there was a zonular dialysis, I guessed, but I could lift up that portion of the hemisphere. So I completed it because I thought there was no vitreous, and I was correct because till that point there was no vitreous. I finished the phaco quite fast, could do a IA, the capsule was intact. I tried to remain at the iris plane and not go below the iris much, but I was a bit apprehensive, so even the lens could be inserted well. Many people would have used a CTR. I wanted to wait till the last moment because there are two dictums that you put your CTR at the end or put your CTR at the beginning. So, but when I was doing an IA, then I noticed that there was an irregularity of the pupil inferiorly. So I put in tricot, and then with my cutter, cut rate low, around 1200 and good irrigation, I did my vitrectomy and saved the day. The iodal dialysis was not hampering vision, but not always are we so lucky. This is a case of hard cataract. Most of us anterior segment surgeons we apprehend that there might be a difficulty when we are doing phaco in this cases, zonular dialysis, etc. I also apprehended. I told my friend Showman, please be there with me so that if I am in trouble, you might have to. But the case was going well. I could rotate the nucleus well. I went for direct chop. And I noticed that it was a bit leathery at the center, but even with the direct chop, I could manage. I could make smaller bits at the periphery, multi-layer chopping, and then the case was going on quite well. So I was happy, thinking that I might not need Showman in my OT that day. He could manage his own cases. So this was it. I finished my case quite well. I was using high density viscoelastic. Everything was perfect. The IOA also went off well, so I was very happy. I could put a single piece lens in the bag. And then it wasn't topical. As I was putting my lens, suddenly the patient moved and the lens went jerking. It went in a jet. And then, but I was not very sure. But then this is what happened when I dialed it in. I could not bring it into position. There it was. There was a big rent somewhere. So I tried dilating. Now there was no other option. So I tried to take out the lens in the anterior chamber, dialed it out, and then I noticed that there was a thrust. So I might have done the trend while injecting the lens. So this is what I did. I used tricot again and then noticed there was vitreous, which was all entangled with my lens. I could not take out my lens, so I went with this. Now we kept our cut rate low, irrigation high, cut it at the place where, at the root, and then again put tricot. And this time we used it more for IA. Then I cut my lens and dialed it out in toto. Again repeated a bit of tricot vitrectomy, and I then noticed that the capsule, the anterior rim, the rhexis was absolutely okay, anterior capsule. So I chose a multipiece IOL, dialed it in I put the haptics and the sulcus, did a optic capture, did a IA. It was a peripheral iodectomy. It was a little bit more, and then sealed my wound. So that was my approach, and please join us in Kolkata in 2024 AIOC. Thank you very much. You can put the video off. So now it is over to Dr. Devdulal for his approach to a vitreous management. He's a posterior segment surgeon, very well-known surgeon with a lot of publications and a huge experience. So Over to you, Devdulal, for anterior by pars plana approach. In
First
the
of all,
discussion of this topic, we have Dr. Swaraj Bhattacharya, sir.
my sincere thanks to the gorgeous lady, Dr. Shudipta Mitra, and my dear friend, Dr. Shoman Mondal, for having me here. So, my topic is anterior vitrectomy through pars plana approach, and what I will like to, dispel any doubts in the minds of anterior segment surgeons that you cannot use a pars plana approach. So that's my kind of, brief here. I have no financial interest. So this is the first case, a 71-year-old lady, cataract surgery done elsewhere. And she came in with the complaint of pain and redness in the left eye for a month. Her best corrected visual acuity in the right eye was 618, the other eye 612. That's the affected eye was 612. And I'll show you the pictures. So this is the right eye with a partly opacified IOL, and the left eye you can see there's ciliary congestion. And in fact, the patient was seen by a corneal surgeon. And if you can see here, that's a large PCR that's there. And of course, the vitreous is not visible in this picture, but that's the optos. And if you look at the specular, not really good. So this is what the advice was by the corneal surgeon: cycloplegics and topical steroids, and of course hypertonic saline and anterior vitrectomy. So he asked me to do it, and this is how we went ahead. So I initially, checked out. I made those ports, the pars plana ports, and as you can see, as I'm entering here, I can see there's a little bit of, vitreous that's being pushed. So just to kind of amplify, that's the vitreous there. So I put in a little bit of tricot, washed it off, tried to wash it off, and obviously it wouldn't wash off because there was vitreous there. And see how easy it is to go ahead behind the IOL and cut off the source of the vitreous. So once you've done that, this is a slightly speeded up video, 1.5 times speeded up, so that I can save some time and be on time. So, and then you go in with your cutter in the anterior part of the eye, and then you just cut out the vitreous. So there's no vitreous that's going to come in from behind, and you are nice and done. So check out, there should not be any vitreous that you leave behind, and you can do a fair job out of it and just close it off. So, and regarding removal of these like trocar cannulas, you do not be so worried. You can just cauterize those parts and they will be nice and fine. So moving on to the next case, this is a slightly different ball game. This is a lady that who had an expulsive hemorrhage in the other eye, and she actually had 624 partial vision, and the cataract surgery per se went off fine. But when she had opted for a multi-piece IOL, and but when I was inserting the IOL, I could see it was a very, very tight globe, and I thought I will manage. So overconfidence did me in here. So I was trying to put the IOL inside, and that's when catastrophe happened. There was this large PCR that happened. So what to do? Obviously, you cannot do a anterior like approach for a vitrectomy. You can't have it. So go in with your cutter through the pars plana approach, and this is again a slightly speeded up video. This is a 1 minute kind of video here. The total actual time I required for this was maybe 4.5 minutes for the vitrectomy. And then once the eye is soft, you get some space and you can dial in your lens and save the eye and save your kind of skin. So that's it. So pars plana vitrectomy for an anterior vitrectomy, pars plana approach rather for an anterior vitrectomy is not something too tough, and I'd like to encourage all of you to go ahead with the pars plana approach. So thank you all for your kind attention.
Thank you, Devdulal. That was a beautiful presentation. I request the next capsule presenters, Dr. Aurubhomik and Dr. Sneha Jain, to be ready. And over to Dr. Swaraj Bhattacharya and Dr. Vaishali for discussing this topic.
Dr. Swaraj Bhattacharya, what I would like to request you to throw some light upon is what are the salient features that an anterior segment surgeon should remember while doing a good anterior vitrectomy?
First, I'd like to thank Dr. Showman and Dr. Shudipta for including me as a panelist in the session. The main principle for an anterior segment, it's definitely a nightmare when you go with the vitreous coming out and the PC rupture, but in adequate hands with cool, calm mind, we can overcome the situation. The main principles being, while doing anti-vitrectomy, we must remember that it must be a closed chamber thing. So, bimanual approach is better, number one. Number two, about the setting. The setting while doing the cut IA means we are cutting the vitreous, it should be in the higher range what the machine permits. Suppose in 1800 to even to 3000 cut rate. Secondly, to identify the vitreous, we should have used the transretinal, and for an anti-segment surgeon, usually in a diluted form, if we use 1:4, probably it helps much because the post-operative rise of IOP can be avoided. One more interesting thing, we should always look for the peaking of the capsule as well as the pupil. These are the areas where the vitreous get detached, they remain entangled into, and these are the points while doing, this has to be taken care of. And we must remember the tearing of the anterior capsule might occur. So you must be very, very cautious while moving the vitrectomy probe in the anterior chamber. These are the very few important points we should look into for doing a good anterior vitrectomy. Right. But simultaneously doing a vitrectomy from the pars plana approach, as Dr. Debdulal has shown us, this is much more physiological because the boy of home returning back to their home, that is in the physiological position, we are pulling the vitreous from inside to their own position, and that probably is the best. And in the coming days, I think anterior segment surgeon should also gear up for doing this pars plana vitrectomy.
Thank you. Dr. Vaishali, regarding the pars plana approach from an anterior segment surgeon's point of view, how, what, in a nutshell, what are the points that you should remember when you are doing a through pars plana approach?
Yeah, thank you so much. Actually, I'm an NTA segment, so I personally I don't have any experience doing a pars plana. So it's like Dr. Sudipta was also mentioning that it's always better that we have someone at for the support. But I've managed the vitreous the way Dr. Sudipta has always. So it's one thing NTA segment surgeons should know is their limitations. Still, when can they try? So it's always better that if you have a support from a posterior segment, so to do it, as sir has rightly said, that is a more physiological approach, but we trying it out like I'm a little apprehensive that anterior segment trying from the pars plana approach. I'm in a teaching hospital, I'm in a government, so we have so commonly seen not only the students but juniors also we do get a lot of PCRs because it's a teaching, so we do anterior vitrectomy without the help of, most of the times posterior segment surgeon is not available. So I do agree that, but one thing is that how much limitations one should know, that okay, at one point we should decide that this case should be forwarded to the position. So that is more important, I guess.
Right.
Thank you.
Dr. Swaraj, initially, I think before we were all talking, now we have all advanced. Initial days, we were also taught about a very, I won't say rude because we managed with that, open sky. You remember the vitrectomy. Whenever there was a bit of, and then I think it was the air bubble, the shape of the air bubble and how much it occupied in the anterior chamber, that we determined if there was a streak of vitreous, and the shape of the pupil if there was a vitreous. Can you just tell us anything about that?
Actually, it was there definitely, but at the present context, using a Centurion machine, and doing up to that limit.
This is not for the Centurion machine, as Vaishali said, because there are sometimes it's the residents. It is for the
Oh,
newcomers.
okay,
They
okay.
may not be using Centurion or maybe doing a SICS. This is a phaco definitely,
Yeah.
but it is
No,
also a
in
cataract
these cases
surgery.
also,
So
if you are doing a scleral tunnel or those things,
Yes.
the SICS, in that cases, I think the suturing of the wound must be there to
Yes.
have a tight chamber.
Yes.
This is very important. And one more thing, our irrigation port should not be on the rent, it should be away from the rent, as well as our vitrectomy probe should be on the level of rent facing up, so that you can see what it is cutting. That is very important.
Just in half a minute, I'd like to tell Sudipta, yes, we do go by the air bubble and the wick also. So we have to teach about the vitreous to the residents. So the wick is also very important, and the air bubble helps us a lot. Yeah.
thank you so much. We had a beautiful discussion in the first
If you
capsule.
allow me a quick
Now,
question,
in interest, oh yes,
very
okay,
quick
okay,
question,
Shugata, go on.
if you allow me. So, whoever is doing Ozurex should be able to put in the trocar. But an anterior segment surgeon without a retinal training, is there any medical legal implication if I put in the trocar and then patient having retinal detachment post-operative?
No, 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 I don't think so. Not at all.
Lubbock?
Not at all.
Can I have a mic?
The most important is that if the anti-segment surgeon, if they can give intravitreal injection, I mean, I don't think that it is a completely mental barrier that you should not.
Exactly.
This is for the other part.
Only thing you have
Initial
to-
management, initial management of only vitrectomy through pars plana is very, very, very much possible, and it should be done. Manisha.
But having said that, I think that if the anterior segment surgeon has had a complication and probably they're not in that mental state, in a haste, you should not really jump into going into the pars plana and into the vitreous cavity. So it is best that if you feel that you are not, in that state of mind to be, handling that complication, then I think that it is in the interest of the patient that you close the case and allow your posterior segment colleague to take up the case, because ultimately the visual prognosis is what ultimately matters to all of us.
Yeah, I would just like to. One
Yeah,
quick way.
okay,
I would
yeah.
just like to address his question that because even earlier I used to do the limbal approach, but since many years now I'm doing as an anterior segment surgeon the pars plana approach. So it is very easy for anyone to do it. It's just that maybe initial one or two cases learn from your retina surgeon. You just have to make one port and you can keep your irrigating port through your side port, and it's very very easy. In fact, now I feel more comfortable with the pars plana approach than the limbal approach because your vitreous management is so much better. So I think it's just our mental block, and now with the new days training we should start training our residents also with this approach maybe.
Yeah, thank you, ma'am. Thank you for this beautiful discussion. Now we move on to the second capsule, and this is none other than Dr. Arup Bhomik talking on scleral fixated IOL, a cataract surgeon's approach, followed by Dr. Sneha Jain, scleral fixated IOL from a posterior segment surgeon's point of view.
Yeah,
So over to you, Dr. Arup Bhomik. Sir
before
is a very famous cataract surgeon.
okay. Before Dr.
all
Bhomik starts,
distinguished-
can I just request the timer to be on? We can't see the timer here. Okay.
4 minutes time,
So,
please.
distinguished panelists, as continuation with the previous discussion, how much the anti-segment surgeon can deal the vitreous. So, my approach for scleral fixation, scleral fixation IOL is whenever we have to deal little bit of vitreous dealing, then we go for the anti-segment approach, but otherwise we always refer to VR surgeon. So most of the cases I prefer to do scleral fixation in the second sitting. So if there is a gross subluxation, I prefer to remove the lens first and go for the second sitting after 1 month for the scleral fixation. I just showing the technique which I am following today. That's a Yamini technique, which is one of the well accepted by all of the surgeon, anti-segment surgeon. So this case I was operated 1 month back. It's a hyper mature case, and absolutely lens was the whole lens was dangling. So I removed with the SICS, and then after 1 month. Now this is a technique. I just making a pars plana irrigation, and it's a really it's a mind barrier of the most of the anterior segment surgeon. We don't generally use the pars plana irrigation, but it is absolutely needed for the when you want to deal the scleral fixation lens or blue dial, whatever. It's a very important thing. As vitrectomy is already done, so I make a scleral marking of the 2 millimeter from the limbus absolutely opposite direction, and now I'm making that needle track. So now this is very important to where you make a needle track, because you have to negotiate your haptic into the needle bore of the needle. So your needle track have to be oriented so that you can easily negotiated the tip of the haptic into the needle bore. Now it is as the irrigation on, you can inject the IOL in the anterior segment. So it is no need to. It is always fear that your IOL can drop, but if your irrigation is on in the pars plana, it's never drop. Now this is a for the side port, as I tell, this is the most important, and the tricks how you oriented your track. Now you can see the needle. I am oriented so much in the left hand, so I can easily negotiated the first. Now it is keep it there. Don't don't remove in the first chance the one by one. Now keep it there, and now it is basically the first needle is hanging. No one is holding that, and now the second one. Second one also very tricky. So as I said, that you have to orient it now. You just pull both the needle simultaneously. So no need to have you don't need no, should not be dependent on the assistant too much. That's he should hold the haptic, so you can remove this. Now your assistant is holding one needle, and you are removing the haptic from the bore of the needle one by one, and now it is in the centration. Now you have to be careful how much you center. Just negotiate slightly forward and backward, and make a bulb with the electric cautery, and it's a bulb is complete. You have to be make a good bulb, otherwise it will may go to the vitreous, and then push under the conjunctiva. Lift the conjunctiva first and push in the scleral tunnel, and the other way other side you will you same procedure. So what I want to give a message. So anterior segment surgeon should avoid the cases where you have to deal too much of vitreous. It is if it is a clean cut case, you can go ahead with the scleral fixation. Otherwise I always prefer to refer the case to Dr. Sneha Jain. Thank you so much.
That was a beautiful presentation. Sneha, it's all yours.
Yes. So, very good morning to all. I'm grateful to be a part of this walking hand in hand session here at the 81st AIOC. So, scleral fixated IOL is done either as a primary or a secondary surgery are great options for treating aphakia, especially when capsular support is insufficient. And it's been done, as we all saw, very wonderfully by Sir. So, I'm Dr. Sneha Jain, and today I will be speaking on SFIL from a posterior segment surgeon's viewpoint. As widely popularized, SFILs can be executed after just an anterior vitrectomy, and it's less time consuming, obviously easier. But as I see, there are always two paths to take. And as a posterior segment surgeon, pars plana vitrectomy is the way to go when it comes to SFILs, especially when I want to do it as a primary surgery in cases of traumatic or iatrogenic nucleus drop, fragment drop, or even IL drop. Also, severely subluxated lenses, as in Marfan's. More complex AFAK cases with concurrent retinal pathologies like retinal detachments and macule holes can be easily dealt by posterior segment surgeries. So there are many ways to perform SFIOLs, but regardless of the technique employed, what is most important is that the site of manipulation of the IOL should be free of vitreous.
And this becomes even more important while attempting to refixate a dislocated haptic or even an entire three-piece lens, where we can just go in, do a pars plana vitrectomy, and pick up the IOL and fix that in place. So pars plana vitrectomy, as we all know, is safer because we can also do a good vitreous-based shaving, that too under direct visualization. We all have heard or encountered of retinal detachments that occur 10 or even 15 years after complicated cataract surgeries. A meticulous pars plana vitrectomy done in the primary surgery as itself could ensure that any traction which is caused by the vitreous loss is eliminated and therefore preventing any future breaks or retinal detachments. So in the setting that a break is found, it can be easily localized and sealed off in the same sitting by doing a vitrectomy. In addition, there's also less chances of cystoid macular edema and troublesome floaters in the post-op period. Also, prolonged post-op inflammation due to retained cortical or epinuclear fragments can be avoided. So, having spoken about all those advantages or situations where a posterior segment surgeon can come in handy, this is a small video of a surgical aphakia that I managed with PPV and SFIL with the XNIT technique. So, after making the two ports, that the two one sclerocorneal tunnel and the two Gabor-Sherriers tunnel, three ports were introduced and a good vitrectomy to remove all those fibrous strands were done before going in for a vitrectomy and doing a good 360-degree indentation to examine the peripheral retina. Then after opening the sclerocorneal tunnel, as here I was using a rigid three-piece lens, used a 26-gauge needle to guide the haptics of the three-piece out of the sclerotomy sites, just near the site of the Gabor-Sherriers tunnel. Once they were exteriorized, they were just fed into the tunnel. Centration was adjusted, and this anterior iridocorneal touch was tried to release as much as possible. Having said that, it's important to address the iris situations and perform a pupilloplasty or an iridodialysis repair should there be a need for it. So it is critical for us to do everything we can to prevent complications like cystoid macular edema, retinal detachments due to missed breaks or unrelieved fractions in complicated surgeries or aphakic patients by employing vitrectomy as safely and efficiently as possible while doing these cases of scleral fixated IOLs to give our patients the sight and the smile they deserve. Thank you.
Thank you, Sneha, for this beautiful presentation. Dr. Shugata Paul, so for a beginner, which approach would you ask them to learn first and why?
See, as a young Turk, I have done quite a few scleral fixated lens, but I don't know, I have lost few patients follow-up. I don't know how many of them landed with retinal problem. Being mature now, I feel, as Arup has also mentioned, and Arup is a master surgeon. He can learn like that, not everyone. So, as Arup has mentioned, I completely agree that don't take up complicated cases. As anterior surgeon, segment surgeon, if it is straightforward, well vitrectomized eye, yes, I will try, still try scleral fixated eye well. But now I am more
Which
inclined to
switches?
do retro iris clip lenses, give good
Which
results. And also, I think everyone in this hall will agree, as an anterior segment surgeon, for retro iris clip lenses, we have to do limited anterior vitrectomy, whereas for scleral fixated IOL, we have to do good core vitrectomy, and on any day, the retinal surgeon will do it better than us. I'm leaving aside Arup, he's an excellent surgeon, but otherwise, I think we should pass the baton on to surgeons like Sneha, Devdulal, then Rupak. They will do more justice to the patient. But regarding learning, there are different ways of learning now with 3D learning system. I think each and every ophthalmologist should try to learn all the scleral fixation technique as well on animal eyes or on 3D virtual reality platform.
One question to Arupda, without any. Yes, yes, yes.
We have a series of 1,500 cases of scleral fixated IOL, and we had only 3 retinal detachments in that. And these were complicated cases, detached nucleus drop, IOL drop, post-VR surgeries. But the incidence of, if you do a good vitrectomy,
No, done by retinal surgeon or anterior segment surgeon?
sir, it's a combination of multiple surgeons, but and it also included trauma cases. So only 3 cases landed into retinal detachment, both scleral fixated IOL.
Yeah, this is with no financial interest, but you actually needed to bend the haptic quite a lot. So what lens were you using, multi-piece of which company? Because some are very brittle, so they actually break.
AR40 is the best one. AR40.
Uh, Arup, one com
Anything in the Indian platform do we
Yeah,
have which is
Oro.
not so brittle?
Oro
Oro
have.
lenses are a bit brittle. That's why I was asking this
there
question.
are one is Alcon 3-piece
Yeah,
lenses.
that's what he has
Uh,
mentioned.
what we were doing previously with Sensar and Technis 3-piece, the problem with Technis 3-piece is it's a C loop kind of a thing. And if you externalize the haptic, many a times the externalization is not very good. So if you start using Alcon MA60 lens, that gives it more haptic space to externalize and put it into the tunnel. It's more friendly.
Points, and I think we are quite enriched with it and not losing much time. We go to capsule 3 where we have Dr. Sangeeta Ray speaking on nucleus drop and IOL drop on table and secondary rescue RFIC lens implantation speaking for 4 minutes. She's a very well-known retinal surgeon from Kolkata, representing Global Eye Hospital. She's a director there. And with her will be Dr. Shoman Mondal, none other than our host today. And he is also a very prolific retinal surgeon. And he'll be talking on when the eye is a Pandora's box, again for 4 minutes. And Dr. Manisha Agarwal, who has been with me as a fellow once in Essen, will be a discussant in this. And we all know her very well as she is right now the secretary of the Vitreoretinal Society. Okay. Over to you, Sangeeta.
Yes. So, good morning, everyone. So, I'm going to present a case in which, okay, the topic is hand in hand, how the anterior segment and posterior segment surgeon should work hand in hand. But in this case, it is definitely not hand in hand. I just want to ponder on some points about how a patient should not be sent to a retinal surgeon. What should be done before sending the patient to a retinal surgeon?
Please go ahead.
A 65 years old gentleman presented with diminution of vision for about an year in the left eye. He had a history of cataract surgery about 3 months ago elsewhere, followed by another intraocular surgery at yet another hospital about a month ago. On examination, his best corrected visual acuity in the left eye was 20 by 400. A retrofixated iris claw lens was then implanted in the eye. Posterior segment examination revealed a total rhegmatogenous retinal detachment with multiple breaks along with a dislocated intraocular lens in the vitreous cavity. 25G pars plana ports were made a superior sclerocorneal tunnel was made. On entering the vitreous cavity, pars plana vitrectomy was initiated, followed by injection of triamcinolone to ensure the complete detachment of the posterior vitreous. Perfluorocarbon liquid was then injected to stabilize the retina as well as to protect the macula if the IOL drops while removal. The dislocated intraocular lens was dislodged from the entangled peripheral vitreous. After making a side port for manipulation of the retrofixated iris claw lens, the sclerocorneal tunnel was completed. When tapped on the retrofixated lens gently with a dialer, hanging like a hammock from the iris, it opened up like a trapdoor. The dislocated intraocular lens was planned to be removed via this trapdoor. The dislocated intraocular lens was held firmly with a max grip forceps by the non-dominant hand and brought up anteriorly. The anterior chamber was entered with a dialer via the side port, and the retrofixated iris claw lens was gently pushed, creating an easy exit port for the posteriorly dislocated IOL. The intraocular lens that had been dislocated was now explanted via the sclerocorneal wound. The retrofixated lens fell back into its original position as soon as it was left alone without any injury to the enclaved iris. This was followed by all the routine steps of retinal detachment surgery. Vitrectomy was completed, followed by fluid air exchange. As has been shown, the retrofixated IOL allows good and stable visualization all through the vitrectomy surgery, even during the fluid air exchange, endolaser, and silicone oil injection. After 3 months of postoperative period, the silicone oil was removed. The intraocular pressure was normal during the whole postoperative period. The best corrected visual acuity following oil removal was 20 by 50.
That was really good. Too many IOLs, and still you managed so well, Showman. Over to you, Sangeeta.
Thank you, ma'am. You connected. So, I'll directly go to the video. So this is how the patient was, there is a music kindly. This is how the patient was sent to me. The wound was open, there was corneal edema. So I injected some BSS and tried to form the cavity, vitreous cavity and increase the pressure. And then I put a suture there. There's a music. Can you just switch it on with a low volume? Thank you. And even after putting the suture, the pressure was quite low. So I used a AC maintainer to put the infusion cannula inside. And when I went inside, I was not informed about the IL drop. I saw the patient in my OPD just before doing the surgery. I saw the IL drop before I went inside. So I went inside, I induced the PVD. There was a nucleus drop and there was an IL drop, which was a single piece IOL. So I injected Tricot, induced the PVD. In this stage, sometimes these kind of PVDs inducing these kind of PVDs become difficult because the lens, the IOL and the nucleus, they sit on the disc, and sometimes we have to move it a little bit with our elimination pipe and induce the PVD. It was easier in this case. Then I extended my wound and I did my phagofragmentation. yes, PFCL can be used in these kind of cases, but sometimes I find some technical difficulties by using PFCL, because sometimes I think that when the pieces are small, they float at the edge of the PFCL and it then becomes very difficult to take it out with the phaco-frag. So I'll just fast forward here because some time has been lost. It was quite a hard nucleus. So when doing phacofragmentation in these cases, we have to make sure that we, before giving the phacopower, we should catch hold of the nucleus first and then give phacopower. Otherwise, the nuclear pieces will chatter around in the vitreous cavity. So now most of the pieces are out. So with the help of a maxillary forceps, I went inside. But as you can see, this is an Indian main lens. It's a quite thick lens. So I was not getting a proper grip. So I was picking it up and just keeping it on the retina. On my third attempt, I could get a better grip and take it out from the anterior root. Then I put a retrofixated IR. And after that, I close the wound with, I always close the wound with air fluid exchange. Many people, they do partial air fluid exchange. Many people, they leave the eye under fluid also, but I personally feel better if I leave it under air, the vitreous cavity under air, and I put enough number of sutures. That's, thank you. And we invite you next year to Calcutta for the AIC 2024. Thank you so much.
Thank you, Shongita. I would now come to Dr. Manisha. Madam, when there's a nucleus drop in the OR, what information would you expect from the primary surgeon to give to you while referring?
So first of all, I must compliment that both the videos were excellent and very elegantly managed complications. As far as the information that I would expect from my anterior segment surgeon, one would be that at what stage the complication happened, what is the level of intactness of the lens capsule for a secondary IOL implantation. Uh, Anything, I would also be very happy if I can know the IOL power, because if I'm planning to explant and put in, then I don't really have to subject my patient again to a repeat A scan, because those eyes mostly are quite inflamed when they are referred to us. And also, it would be a better idea to medically manage those patients till the cornea clarity is there for a VR surgeon to intervene. It's no point, referring the patient to me where I say that, I have to hold on to some more time till the cornea allows me to do a VR surgery.
Okay, Dr. Abhindra, one quick comment.
In your case, the patient had a lot of SK. So I'll reinstate what Dr. Manisha has said, that let the cornea clear and then take up for the second surgery. Because once you take up for the surgery, the cornea will absolutely become white post-operatively and the blame will come on you, not on the anterior segment surgery. And there are multiple studies which shows delaying nucleus removal by week to 2 weeks
By a week or two gives
does
better
not
result,
alter the final visual acuity.
But the nucleus drop itself can cause the high pressures and corneal haze.
That you can manage with anti-glaucoma, but because if you don't have a good cornea, you won't be able to do a good definitive job in the retina.
Agree.
You are working in a hospital where anterior segment and posterior segments are there simultaneously. These are tips for the person who don't have vitreoretinal support and has to refer to the retina surgeon. So you can ask your surgeon to come into the OR and complete the surgery. That we do it in our institution where VR backup is there.
So I think
and
what
you
we
want
are,
an absolute, you want to tell the VR people the absolute truth. You've tried the lens has fallen, how much the capsule is. Absolute truth, completely of what happened.
And so the suture is very important. It should be sutured. The wound should be
Absolutely.
sutured before sending the
I think
patient.
that's very important
Because
point.
here, sir, yeah, initially I thought of sending the patient back because of the corneal edema. I was a little bit skeptical about going inside, but I thought that the suture has not been put. It is hypotenuse, so corneal edema would not go. So I took up the patient and I'll put a suture and then finish the surgery, which was actually not the right decision. Actually, the cornea should settle down and then we should go inside with further.
So sometimes these patients are even referred, as you mentioned, that without suturing they can have choroidal detachment.
Yes, ma'am.
And those choroidal detachments are primarily because of hypotony and not so much because of the inflammation. So when you actually just suture the section and you reform the globe with the normal IOP, those choroidal detachments actually go away.
Yes, ma'am.
Thank you,
Okay, in
Dr.
interest of
Sangeeta.
time,
Yeah.
we move on to our next capsule. And in that, we have Dr. Dr. Samira Nayak and Dr. Mrinmoy Das. So, Dr. Samira?
No, Dr. Minma is going to start with his presentation now.
Okay,
followed
no
by
issues.
Dr.
So
Samira.
Dr. Mrinmoy Das, whom we know as a very prolific cataract surgeon, is going to talk on pediatric cataracts, roadblocks and management, 4 minutes. Please go ahead, Mrinmoy. And Dr. Samira, please be ready.
Good morning, everyone. So this is a video. So my topic is pediatric cataract, roadblocks and management. I have no financial interest. So always you have to calculate the horizontal corneal diameter, because if it is less than 10 millimeter, we usually avoid to put intraocular lens in these cases. The second roadblock is there is difficulty in anterior capsular axis. To avoid this, you have to use high density viscoelastics. Always use trypan blue because it can decrease the elasticity of the capsule. Then usually I usually started with the cystitome to make a nick over the anterior capsule, because with forceps it is difficult, and then with special microrhexis forceps through the side port under the use of high density viscoelastics, so the chances of anterior capsular axis success is much more, and it should be more than 5 millimeter. Otherwise there is high chances of anterior capsular axis, anterior capsular phimosis in this age group. The cataract surgery in basically, as it is a soft cataract with irrigation aspiration in usual method, it is sufficient. Phaco power sometimes you can use, but it requires less phaco power in this case. The next step is the most difficult, that doing a posterior capsular axis. So you can do it manual or you can do it with a vitrector. So the conventional technique is posterior axis should be manual. For that, with a cystitome, nick was made in the center part of the posterior capsule. Then again with the microaxis forceps, it is tried to be done. It should be around 4 to 4.5 millimeter. Nowadays, the retroillumination has helped us in great way, because previously without retroillumination it is very difficult to make a posterior capsular axis manual. But the learning curve is much more. But with the vitrector, the learning curve is very less. So now I usually put the single piece IOL in the bag. Sometimes you can put multi-piece IOL if the anterior capsule has breached. Here the IOL power you have to under corrected according to the Dahan's law, or you can use the rule of 7 so that to decrease the post-op high myopia. And then with a vitrector, I usually do a anterior vitrectomy, because otherwise if you do not if you don't do the vitrectomy, the anterior vitreous face can act as a scaffold to grow the posterior capsular opacification or posterior capsular epithelial cells proliferation. And as it is a pediatric cataract, the scleral rigidity is very low, so always you have to put the sutures of every wound. So the take home message are measure horizontal corneal diameter before surgery, use high density viscoelastics, IOL should be implanted in the bag, anterior vitrectomy is mandatory, wound suturing is required. There is one small video where I am doing the posterior axis with the vitrector. Just manipulate your vitrector behind the IOL and make a nick in the posterior capsule, and you then just gradually you just do vitrectomy and you just increase your posterior capsular axis. And the other steps are same as before. Thank you so much for patient hearing.
Thank you, Mrinmoy. Over to you, Dr. Samira. Samira is going to speak on management of complications during pediatric cataract surgery.
Fantastic presentation. Uh, now, which one would you prefer while you are doing surgery? I mean, doing pediatric cataracts. You would prefer the cystosome approach or the, manual with the vitrectomy approach to do the PC?
Yes, basically I usually do manual if the posterior capsule is clean and clear. But when there is some fibrosis, maybe some traumatic, when it is not, it is very difficult to make a manual rexis. Then I would, of course, I would go with vitrector. With the vitrector, yes, it's fine, absolutely fine. Sometimes the problem is when at the end you hydrate the side port and endochamber go deep. Sometimes it may run away.
Okay.
The vitrector axis, but with manual axis it never happens.
It never happens.
It never happens.
Samira.
How do you create an opening or a rent in the posterior capsule?
Yes,
How do you create a rent in the posterior capsule? That's the key to start the posterior capsular access.
Yes, sir.
So can you give us some tips how to start the posterior capsular access?
Sir, first,
In interest of time, can we just take this answer just after our presentation?
Okay.
Yeah.
No, we were just waiting for her to start. It was not loading. That's why we were discussing.
Okay.
Yeah. But if she's ready, then we can start. Yes. Okay. We'll come back to you.
Thanks for the invitation. In this presentation, I'll try to answer 4 questions related to vitreoretina interventions in pediatric cataract surgery complications. The first question is, how often do a pediatric cataract surgeon require a vitreoretina intervention? To answer this question, we did a retrospective chart review of pediatric cataract surgery from 2011 to 2023 at 4 campuses of LVPI. We included 12,821 babies with congenital or developmental cataract, and we found that 77 babies actually required some kind of VR intervention after pediatric cataract surgery. So in this short cohort, we have included 93 eyes of 77 babies, and males were more than females. There were 16 babies who had bilateral pediatric or developmental cataract and required bilateral VR interventions. And in this cohort, congenital cataract and developmental cataract were equal in numbers. The second question is, what are the scenarios where pediatric cataract surgery complications require vitreoretina interventions? So the most common indication is retina detachment in this cohort, 53 in number, followed by IOL subluxation, dislocation, and acute postoperative endophthalmitis. The other indications were expulsive hemorrhage, which is opacification or JIA-related, uveitis-related opacification of vitreous, aphakia needing secondary IOL, PHPB stock, remnant of PHPB stock, and lens matter in vitreous cavity, posterior capsular opacification. Couple of cases we can discuss over here. This is a case of pediatric cataract surgery this is a boy who had received pediatric cataract surgery 5-6 years ago, and he presented with retina detachment. Usually we see very bad, with PVR changes, retina detachment with a lot of PVR changes, and this boy is a one-eyed boy, and he, while coming to the OR, he again sustained a blunt injury. That's why a lot of fresh hemorrhage you can see. So in this particular case, PVD induction is very crucial, and of course PFCL was used and retina was settled with PFCL in situ, and in a second sitting, we did a silicone oil injection, and he's doing good. Yeah, there is some issue with the video. This is another scenario where retina detachment is there. This child is also, this child had received pediatric cataract surgery, and now with retina detachment. This is a Datura type retina detachment, I would say, almost closed funnel RD. And in this, without PFCL, retina was settled. This is a case of IOL subluxation. This is a foldable IOL which has gone a little bit inferiorly, and a VR intervention was required, and since the sulcus was present, I put the IOL in the sulcus after doing a scleral tunnel incision. So a pars plana vitrectomy, we do almost all cases if there is IOL, secondary IOL or glued IOL we are planning. This is another case of aphakia requiring glued IOL. So I'll skip few of the videos, and it's not moving.
Manisha, in the interest of time, can you just conclude?
Yeah,
the take-home
come to the
messages.
conclusion. It's getting hanged.
Now, Mrinmoy, you were answering a question. Can we take the answer first? Okay.
Where I am thinking of doing a aphakia, because there is already anti-capsulosis done. So if posterior capsule may sometimes ran away, then it's also not a big problem for me. So first, when I am confident doing the posterior capsulosis in aphakic cases, then I have started to go in pseudophakic cases. What I have to tell that, don't depress the posterior capsule too much so that the maneuvering would be difficult. So put viscoelastics in antechamber, but not too much. And always go through the side port so that the viscoelastic should not come out through the main port. That is, and you have to always try to make a smaller axis. If it becomes so smaller, whenever you are going to do you are going for vitrectomy, you can enlarge it with vitrector.
Minmay, what is your cut rate when you're using with a cutter? You're doing a vitrectomy.
Usually, always cut rate is highest. Whichever is highest in the machine, I use that.
Okay, thank you. And now we ask Dr. Manisha Nada. Yeah, ma'am, Manisha. Yeah, to discuss, to tell us any other important point when dealing with pediatric cataracts. You have a point? Okay.
It's okay. Now it's fine. So when we do pediatric cataracts, we need to know the elasticity of the capsule should be is there. There's always a high elasticity, so we need to make a rexis which should be smaller. That should be 3 to 3.5 mm, and you need to do so that there should not be any phimosis later on. And we can do anterior vitrectomy or posterior vitrector can be used for doing a PCCC. And this biometry should be taken well, care should be taken, and PCO should not be there. Anterior vitrectomy should be carried out in all the cases, and we can use trypan blue for CCC. These are the points we should take care in any case of pediatric cataract.
Our chairperson, Dr. Natarajan sir, has joined us. Welcome, sir. We've already done 3 capsules, so rest 3 we want to hear.
Thank you. Sorry,
this was on pediatric cataracts. Would you like to add something, or should we go to the next capsule?
No, go to the next.
Okay. Vaishali, just a quick word. And the next capsule is by Dr. Kavita Rao and Dr. Rupakkanti Viswas. Please get ready.
About the PPCI, my suggestion for the beginners is that it's always better to place the IOL and then with the Sinsky soup, then you try out the PPC. So it's much better that way. So you're also aware of the optics while you are doing the PCC. Thank you. That's it.
Thank you, Vaishali. Okay, so talking on corneal complications post VR surgery for 4 minutes is Dr. Kavita Rao, who is a very well-known cataract and cornea surgeon.
Thank you so much. Very good morning, and thank you, Dr. Sudipta, for having me for this session. So even though we are not working hand in hand, and these are sequential surgeries, but we are still working as a team, and it's very befitting that our retina surgeon is here for me when I'm making this presentation. So I'll be presenting two cases showing managing corneal complications after retinal surgery. Looking at this, this was a paper which has come out from the Boston University. Here, what they have looked at, they have divided two groups. They've tried to look at corneal complications post retina surgery, and they've divided into two groups, one with silicone oil use and the other without silicone oil use, to see if it is the silicone oil itself which is causing the problems. And they found that it was actually the etiology due to which the retina surgery was done. Essentially, if it was endophthalmitis, if there was trauma, and the silicone oil cases usually had multiple retina surgeries. I think Dr. Natarajan also would agree, for some reason, sometimes after the SOR is done, the cornea just decompensates and the patient then needs a corneal surgery. So this is one
Kavita,
patient.
often on the screen is going, is there? Yeah, I told them they're saying there's some effect. Is there? Or you just go on.
No, there's
Off.
no effect on.
The screen is again off. Sir.
Why is the screen switching off? Is the contact loose?
See anything? Really sorry for the
Very
AV
sorry, it's
problem
been working
this
well
time.
in all the other halls.
Yeah,
I'm not sure what's
so-
going on in this hall.
Kavita, can we ask Rupak
Yeah,
to
sure.
go on?
Sure.
Just start.
Please go ahead, sir.
Please give this one. Okay, this is on.
It's come?
Yeah, it's come.
Right.
Go on.
So in this
really
patient,
sorry.
he's a young guy. Again, it's off. I don't know what is going on.
Rupak, start, yeah, please.
What should I do? Should I load it?
Very good morning. I would like to thank Dr. Sudipta and Dr. Soman for conceptualizing this nice concept of walking hand in hand, which is not for the professional as well as in your personal life. Also, if you can maintain this balance, I think that gives you a lot of confidence in life. And this is my financial disclosure. And when Dr. Sudipta sent me this slide first, then I was just reading. I was a little bit of in a hurry. So it's a survival toolkit for posterior segment surgeon, which harmonizes. Then I was out of my shock. And then how come it is hormonal? Few things comes into. Then I read it properly, and then I saw, okay, it is a harmonization of anterior and posterior segment surgeon. So then when I came down to the reality, then this is the study which give me a lot of inputs into it. So practically, this is a very rare complication. So I mean, all the posterior segment, anterior segment surgeons are so brilliant that I could hardly find any kind of posterior segment complications. So, but of which there is the few things which is you go to inside the eye, there are few things which is going to happen, like cystoid macular edema, endophthalmitis, retinal detachment, suprachoroidal hemorrhage. But which is more striking is that graft dislocation to the posterior segment, which we call as a disc over the disc, or the ischemic optic neuropathy. These are very rare incidents, but yes, there are literature reports for this. So incidence out of all those, the incidence of cystoid macular edema is one of the most important part of it. Can you give me the pointer, please? So the incidence varies from the case to case and from the surgeon to surgeon. But again, on an average, it has been seen that the DMEC has a little more incidence of cystoid macular edema compared to the DSEC, and the triple DMEC, obviously, the handling is little more. So the possibility of CME is more. This is one of the dreaded complications, very rare, but yes, once it happens, then you need to have the utmost importance and leave everything and be with this, of which this endophthalmitis, the fungal endophthalmitis, which is most common, and this is mostly from the candida is one of the most important, and then you need to do vitrectomy and management according to the endophthalmitis protocol. I'm not going into the detail of that. Choroidal detachment incidence is again is very, very less, which is near about 0.05%, but yes, it can happen. And retinal detachment, again, incidence is less, 0.1, 0.5 to 1%. And again, in a very clean case, obviously the chance in Fuchs, the chance is much less, but when you are dealing with the vitreous, then the chance in a pseudophakic or aphakic bullous keratopathy, then the chance of retinal detachment goes higher. Now, this is disc over the disc. This incidence is a rare incidence, but again, yes, it can happen. So there are multiple, case reports are there. So I'm just giving a few example of that. And I mean, I could manage of getting one video for this. Sound is not coming now. So anyway, there was a significant gap here through which this disc has fallen over in the vitreous cavity, and after doing a complete vitrectomy, this disc was rescued and then again reput. So this is just an example for that. And the incidence again varies because it purely depends upon the situation. You have to have to go to the posterior segment, there should be a defect in that iris IVL diaphragm. Ischemic optic neuropathy is also just a rare complication. Thank you all, and I all invite you for next AIOC at Kolkata. I'm sure that you will enjoy the city of joy.
Very important points discussed by Rupak. Kavita, are you ready? Okay, so in interest of time, we'll wait for this capsule to finish when Kavita, and I would request the next capsule presenters, Sahiban, Dr. Sahiban, and Dr. Krishnendu to please come and present. Shahiban is a very well-known anterior segment glaucoma and cataract surgeon. She's going to talk on secondary glaucoma following Weir procedures, and Dr. Krishnendu Nondi will walk with her in SOS from glaucoma posterior segment interventions. All over to you, Sahiban. Can we have Sahiban's presentation?
Thank you for inviting me here. I'm truly honored.
Please have the presentation there. Sir, please have this presentation there.
So my talk is going to be on secondary glaucomas following VR surgeries. Now there are only three modalities of management of these cases. First being medical management, then second is doing a trabeculectomy, third would be implanting a glaucoma drainage device. So I thought, what can I deliver in my lecture over here? So my talk, I'm trying to focus on try to focus on what indications there are for different managements of these cases, and also what's interesting is me showing you a case of a new glaucoma drainage device that has entered the Indian market only last month. It's called the Ahmed Clear Path, and this got an FDA approval in 2019. I was lucky to be one of the first few surgeons to have an experience with this, and we'll see how it offers an advantage over and above the existing tube shunts. Good morning, everyone. So in the beginning, the challenges that we face in glaucoma management. So how do I fix them? Okay. The challenges in glaucoma management we usually face is the fact that we have refractoriness to conventional medications, aggressive nature of the disease, you have prior conjunctival scarring, multiple surgeries have been done on these eyes, and also any which way they have very poor visual potential. It's very important to also measure your IOP accurately so that you can plan your management. Goldman applanation tonometry remains the gold standard. Avoid non-contact tonometry in any of these cases, especially in gas-filled eyes, because it can underestimate the IOP. Tonopen is the reliable second option after Goldman applanation tonometry, and even an rebound tonometry can be tried. So let's look at this first case of a silicone oil induced glaucoma, an IOP of 42 millimeters of mercury. Did a late presentation. The patient is aphakic. There is silicone oil even in the macula. And on gonioscopic examination, he had silicone oil in the angle and more than about 270 degrees of peripheral anterior synechiae. So now what could I have planned for this patient? Now this patient had bipolar rim loss. There was advanced glaucomatous damage by then seen through the silicone oil in the fundus. So to begin with, he had a late presentation, very high intraocular pressure, advanced glaucomatous damage, and synechial angle closure. So naturally this patient was planned for a silicone oil removal and trabeculectomy. The fact that only silicone oil removal was not done is because studies have shown time and again that IOP remains persistently high after SOR in these cases especially. Let's look at another case here. The management was different. The pathology was the same. This was an early presentation of a silicone oil induced glaucoma wherein all the angles were open. You can see that the disc is fairly okay. The IOP is about 32 on 4 anti-glaucoma medications. Now this case was managed well with only medical management. Let's also remember that 78% patients can be treated fairly well with AGMs alone. Use aqueous suppressants, prostaglandins to be avoided in cases where there is active inflammation. This is the third case. The ASOCT beautifully shows that there was synechial angle closure. There is advanced glaucomatous damage as well, along with a disc hemorrhage, and IOP was high on maximum therapy. This patient underwent AGV implantation. In pseudophakic and aphakic eyes, it's better to put the tube in this pars in the sulcus, to avoid corneal complications that look like this, with an anterior segment placement of the tube and a tube corneal touch. This is the fourth case that underwent pars plana vitrectomy, lensectomy, and IOL implantation, status post-trauma. Now you can see in the first picture that there is a severed conjunctiva over here because the tunnel was made. There's a vicral suture underneath also, which was made according to the VR surgeon to suture a sclerostomy with a burn. So this patient underwent the tube implant that I was talking about, which has just been introduced. This is called the Ahmed clear path. The advantage of this is that it doesn't require a very large conjunctival peritomy. You can see that I wanted to save the conjunctiva, so just about 3 millimeters of a conjunctival cut. You can actually fold the whole tube as a taco, insert it in through that small incision, unfold it, place it there. Even the scleral patch graft doesn't need to be either sutured or any glue has not been used, because it snugly goes into the conjunctiva. It's not a wide conjunctiva, so the patch graft is not mobile. It snugly fits underneath, and then you put interrupted either nylon or vicryl sutures, and then your case is over. So this device looks very promising. This is post-operative 1 week picture wherein you can see that there is no tube exposure. The scleral patch is well opposed and well placed, no displacement. The tube you can see in the sulcus, not occluded. The patient's doing very well. Thank you so much.
Sahiban. And over to Krishnendu, who is one of our saviors of anterior segment surgeons. He's a prolific posterior segment surgeon. And Krishnendu is going to talk on SOS from glaucoma posterior segment interventions.
Good morning, everybody. So thank you, Sudiptadi, for our kind introduction. So my talk will be concentrating on the situation where my glaucoma friend needs me in my OT. So this is few scenario. The most common thing, with permission from VR sir, our glaucoma teacher, with permission I am speaking. This is the first case often we encounter in our day-to-day practice, like malignant glaucoma. So what we do actually in malignant glaucoma, here we do phacoemulsification. The patient presented with shallow anterior chamber. Trap was done elsewhere. There's a cataract, shallow ASI. So we plan to do phaco. Then the Ahmed valve glaucoma device was introduced. Then conventional 3-port vitrectomy is done. So this is how we have to place the vitrectomy port little away and adjust little differently to accommodate the place of Ahmed valve. So this is a different position, unconventional position of the port system, and then conventional vitrectomy. We have to rupture the hyalate phase, the anterior hyalate phase, and do core vitrectomy as far as possible in order to prevent further attack of malignant glaucoma. So next is the hemorrhagic choroidal detachment, either on table or post-operatively, that can be managed by VR surgeon. Firstly, with the giving of oral steroid with caution, not much of time, less 14 days post-operatively, and see for early clot lysis. Now we have to close the incision if it is intraoperative, or in post-operatively we need to see the serial ultrasound for the clot lysis, because if there is a clot lysis we can drain it. Now draining should be done around 7 to 14 days following the primary surgery, and it should be done at the multiple position because to clear the blood completely. Now, modern days there is a drainage system by trocar, introducing trocar and cannula in the suprachoroidal space, placing an anterior AC maintainer and drain the fluid from the different quadrant. But the postoperative result is not good. Retina might settle down, but the visual acuity may not improve much. Second most common situation, serous choroidal detachment, can be managed medically only, but you have to differentiate from the serous choroidal detachment from the hemorrhagic choroidal detachment because different scenarios. The most dreaded complication is the endophthalmitis, blebitis, whichever you call. It can be early, it can be late. We have to do ultrasound cautiously and may need early vitrectomy in order to save the eye. Maybe we need to cut the bleb portion also. Another case is nanophthalmos, very difficult case to manage due to short axial length, hyperopic eye. Often the presence, there is a multiple choroidal fold, retinal fold, exudative retinal detachment. How it can be managed by our glaucoma surgeon, combined vitreous surgeon, is a sclerectomy with sclerotomy, where the full thickness, partial thickness scleral flap is made, it is taken out, and the linear sclerotomy is done at the center between rectus muscle. It can be done in 4 quadrant, it can be done in 2 quadrant. Better we should perform in 4 quadrant in order to get better result. And the post-operative outcome is gratifying in some cases. Lastly is the cyclodialysis cleft, often see after post-operative trab or even after cataract surgery. Patient present with loss of vision, hypotony, sometimes deep anterior chamber. You can see this kind of picture where there is a disc edema, lot of choroidal retinal fold, and we have to stop steroid and give atropine drops. And sometimes atropine drop may not be sufficient enough. We may have to do cryotherapy, may have to go surgically in order to fix the cyclodialysis cleft. But in this case, we have applied atropine drop, withdraw the steroid, and it settled down in 3 months' time. This is the UBM picture where the cyclodialysis cleft is there with the ciliary supraciliary effusion, and after 3 to 4 months it's closed. And lastly, the post PK the Ahmed valve implantation, where the Ahmed valve cannot be placed in the anterior chamber, we have to place it posteriorly at the pars plana, where we need to go do the vitrectomy and allow the glaucoma surgeon to place the pars plana valve posteriorly. Thank you for your
Krishnandu.
patience.
That was great. Due to repeated technical glitch, we have lost a few minutes. So I request the next moderator to allow me Dr. Kavita Rao to present, please.
Thank you so much, and I apologize for the technical glitch as well. So as I was saying that, I was talking about this study which talks about looking at corneal complications post-retinal surgeries, and they divided into two groups, silicone oil versus not silicone oil. And they found that it is not exactly just the silicone oil, but maybe the multiple surgeries, trauma, endophthalmitis, which causes the corneal complications. This is a patient who has corneal edema, he's had trauma, multiple VR surgeries, including SOR. So we're planning, like we did a 4th row pupilloplasty first on him. I also planned an endothelial corneal transplant in this patient. So in cases of corneal edema, even though it looks like it's not a lot of edema, but when you're trying to do it on table, it's definitely very difficult. So you can use an endo illuminator after switching off the slit lamp light, and that really helps. So after you've done your pupilloplasty, you can strip the desmids, and this is how you get a bubble and you make the prepare the donor cornea. And I'm sorry, I don't know why the whole video is not playing. Anyways, at the end of surgery, this is how it looks. This is the second case. This is a girl patient with multiple VR surgeries for diabetic retinopathy. Again, after SOR, suddenly like the cornea just decompensates because there's such dense corneal edema, whether to do a PDEC or PK. ASOCT always gives the answer. As you can see, most of the edema is epithelial, and so PDEC was the answer in this patient. Similar surgeries, once you just remove the epithelium, you prepare your corneal button and you inject the cornea into the prepared PDEC graft. As we know, the endothelium always, like a biceps curl, so you can identify the edge. Using the endo illuminator also helps in figuring out the edge. So in the interest of time, I'll just move forward, and this is how the patient looks. You can see that this is just about a month post-op, and the scarring has almost gone. So thank you.
Thank you, Kavita. And yeah. You want to say something?
Yes. Yeah, so wonderful presentations by Dr. Kavita and the VS Dr. Rupak. So just one or two points. Post vitrectomy, whenever we are doing endothelial keratoplasty, the AFL is to be taken care of because vitreous is devoid. The vitreal cavity is devoid of vitreous. So I think that is one thing which one needs to know. And the second, for the retinal complications, I would just like to say that now a lot of us are doing keratoprosthesis, so a retina surgeon should be aware of like doing a good retinal evaluation through keratoprosthesis, and keratoprosthesis are the ones who have maximum retinal complications like vitritis or retinal detachment.
Thank you so much, Dr. Sheetal, and yes, sir.
Yeah, for the glaucoma, both were very good presentations. Just one point, you can also do an endocyclophoto or a diode CPC, especially if there's a poor visual prognosis as an additional thing. For the malignant glaucoma, what you would also can do is want to do is an iridozonulo hyaloidectomy, so that you have it a complete one chamber, so that you can break the attack. And otherwise, fantastic presentations, all of you. Thank you.
Yeah, one word from our
I
chairperson,
think,
sir.
no, the main thing is I think vitreoretinal surgeons, we produce the pathology produces the corneal complication. That's why I remember, I should confess, in '84, Dr. Steve Charles used to say, whatever comes in the way, remove it. And we used to do sphincterectomy and lensectomy, and finally end up with 360-degree PAS, and finally glaucoma and intractable glaucoma. So I used to do endophotocoagulation in '86 in Shankar Nethralaya, and then also called a filtration procedure, pars plana filtration. But I think I'm glad to see all the last three presentations for cornea and glaucoma complication can be managed. But I think one word of caution for both anterior segment surgeon and posterior segment But I think we should be upright in telling the patient the risks of silicone oil when we use. Because when the patient comes with a complicated detachment, I'm sure a lot of surgeons are afraid to talk about complication, including, I'm not afraid, but I think we are not shy. We are shy to talk about the post-operative complications of silicone oil. And I think now, since I have the reputation, I can upright tell them that there are all complications with any procedure, and probably monitor particularly the pressure when the pressure goes up even above 20. Make sure every patient is seen by a glaucoma surgeon in our hospital. That's a luxury, but at least retina surgeon should keep checking both for cornea and glaucoma and make sure you prevent the complication rather than having optic disc pallor and then doing all this. And finally we do an excellent cornea surgery by Kavita and the optic disc will be pale. So I think the idea will be to refer the patient to the cornea surgeon and to the glaucoma surgeon or manage together at the time. I think the excellent session by Sudeep and all the people on the stage and the speakers. Thank you, Kavita.
Thank you, sir.
For
I thank the chairperson, the participants, the panelists, and just before I hand over to the moderator of next session, can all the participants just gather for a quick photograph, group photo?
Rashmin can go.